stop you getting out of
Yeah,
frame.
yeah. How they make sure you don't move.
Wait for the go ahead.
Yeah, we'll get.
Oh, good. All right, excellent. Welcome to the UCLIC Research Seminar today, and thank you all for finding the time and the space, the room. It's great to have you all here. We are pleased to have Amit Baumel coming from the University of Haifa in Israel to visit us today to speak with us. And so I'll turn the time over to you, and at the end we will have question time as well.
Cool. Thank you. Okay, so thank you for your time. I'm very happy to be here. A bit about my background. I'm a clinical psychologist, but also a past high-tech entrepreneur. And in my academic career, I researched scalable digital mental health interventions with the idea of using these interventions to close the mental health treatment gap. The mental health treatment gap means that at any given time point, most people with mental health problems do not receive any kind of support. And also the duration of untreated conditions is quite high for those who eventually receive support. And the promise of digital mental health interventions for public health is that they could potentially be accessible to people at earlier points of time, of illness onset, and of course, in a cost-effective manner. But there are two snapshots that I would like to present to you, two challenges, if you will, with this that relate to this promise. The first is that people poorly engage with programs in their unguided forms. This is a study we conducted several years backwards, where we examined the usage of the most popular mental health apps that are out there. We took similar web platform data that records user traffic worldwide with millions of users, and we looked into the 93 most popular apps. And what basically you see here is user retention rates, right, for 30 days. So for example, on day one after app installation, which happened on day 0 here, approximately 70 to 75% of people keep open the app. But after 14 days, you can see that only approximately 5% on average keep open the app. Clearly, this is not the usage that we would expect of something that creates behavioral change to people. The other snapshots is that there is very low desirability or uptake, if you will, for guided, human-supported digital mental health services. And MindSpot presents a very good example for it. It's probably one of the most utilized digital mental health services in the world. It's Australian, funded by the Australian government. So basically, people in Australia, they can go online, they complete an online assessment battery, they then talk with a clinician remotely, they can talk about their conditions, they receive a report, and they can decide to take a digital course on depression, anxiety, and so on. During this course, they will receive human support, on average 2 hours. It would be for chats or phone calls. And from the initiation of MindSpot till 2019, we see this very interesting trend. So we see that there is an increase in the percentage of users who go ahead and seek report about their mental health assessments. However, we see a strong decline in users that actually wants to use the digital courses, the digital mental health services that are out there. So we have two challenges: users poorly engaged with programs in their unguided forms, and we also see low desirability for digital mental health services that are human supported. And how can we overcome these realities is part of my research, and this is what I'm going to talk about today with these 3 proposals. Just going to grab myself something to drink. Okay. So the first proposal is that the digital intervention design should utilize technological strengths to foster change. Therapeutic persuasiveness is a design concept that I work based on, that really targets using technological advances in order to help people make changes in their life. So you see the criteria it involves. So call to action, for example, is whether the program saliently set up desired activity for users and inspire them to conduct them at their environment. And ongoing feedback, for example, is whether the program presents feedback on the therapeutic activities that users were engaged with and offers the right steps or information afterwards. And how we came up with these criteria. So basically, we conducted a comprehensive systematic review several years ago, trying to capture all the criteria of digital health interventions that are out there. We found 90 sources of information, and what we found out that there is a very interesting overlap between criteria that comes from persuasive system design, human-computer interaction, and behavior change techniques in psychology. In a nutshell, this is therapeutic persuasiveness. Another important aspect is that you can also think about therapeutic persuasiveness as a scale. So we can train raters to play with programs and then rate on a scale from 1 to 5 the quality of call to action and all the other criteria, and then the average of these all criteria gives us a score of therapeutic persuasiveness quality. So for example, after they play with the program, they will give, in terms of call to action, a very poor 1, score of 1 if the action items are vague, implied, or hidden, and they will give a very good score if the desired therapeutic activities are well targeted and the program stimulates, inspires users to complete these activities. Therapeutic persuasiveness quality scale is one of 11 independent quality scales that we developed in this systematic review that we conducted. It's quite reliable. This is important. We'll talk about it later. But basically, what it means, if I teach 2 different raters to rate the programs, and each of them independently rate them, they get the same scores. So it's a transparent concept. People can agree what a quality of very good or very poor means. And with that in mind, having this enlightened quality of assessment, I co-founded Mindfuls.io, which is an app recommender website where we rate programs from all over the world in English and provide details about them to users. Right now, the website is under renovation. You see the original, actually, website from, this is my taste 7 years ago, okay? So you can have resource, and by the way, it's going to be up and running in 1 month again. So under resources, you can download the manual of Enlight, how we reach the ratings and so on. And if someone press find the program, they're going to get this program list. They can filter programs based on different aspects, including Enlight star rating. And if they press one of these programs, they get some information about it. They see Enlight ratings and also notes for clinicians how they could incorporate the program in their practice. So with that in mind, when we rated the first cohort of available health interventions, we found out this interesting aspect. So we found out that actually a bit more than 50% of the products that we rated had a score of above than fair in content. Content means how accurate the information that is provided to people is, whether it's evidence-based, complete, concise, and so on. So for example, it teaches CBT for targeting anxiety disorder, mindfulness for stress reduction, and so on. But then we found out that also a very small number of these products that have a score above than fair in content have a good enough score or more than fair score in therapeutic persuasiveness, which basically means that most programs that deliver evidence-based content are not designed to encourage users to make positive behavior changes or other changes in their life. With that in mind, we also wanted to check whether our ratings of these different programs, they predict real-world usage of them. Okay, because we have all these ratings that people played with, raters, and we do have an availability of similar web platform that records user traffic all over the world. And we also collaborated with Microsoft Research with another data set. And what we found out, that out of all the quality metrics that we had, including user engagement, usability, visual design, whatever, therapeutic persuasiveness was the most robust and stable predictor of real-world usage, meaning that when we rate the program and it gets a very good score in therapeutic persuasiveness, people utilize it more. However, this is not casual relationship, right? Many things may relate to that. And with that in mind, we wanted to test the casual relationship of manipulating the the impact of therapeutic persuasiveness. So I took a I built actually a digital parent training program aimed at treating child behavior problems. And I built it based on the standard, on the state of the art, what's currently out there. And then I enhanced its therapeutic persuasiveness quality based on the criteria I mentioned before. And I will later present how it looks in the program. And what I wanted to check is to allocate parents to both programs and see whether there are differences in usage, clinical outcomes. And in this way, I have causality. I know that enhancing the quality of therapeutic persuasiveness results in better engagement and outcome. So the standard program has this e-learning experience of interactive modules covering 5 themes that relate to parenting skills that are meant to combat their child behavior problems. If you can read this, congratulations, you know how to read Hebrew, okay? The enhanced program, in each skill phase that the parent learns a certain skill, there is also a 1 to 3 weeks focusing phase that follows the e-learning module. This is the difference between the standard and the enhanced therapeutic persuasive program. So what is a focusing phase? Let's take an example. We want in the program that parents will have positive interactions with their kids. It's very important for us because we want them to do that before we teach them more direct ways of overcoming their child disobedience, to build the relationship with their child first. So we do give them good psychoeducation about positive interactions with ideas that they can do at home. This you have in the psychoeducation itself. However, from a therapeutic persuasiveness perspective, this is not enough because parents have competing activities at their home. And it's not that most parents don't want to have positive interactions with their kids. You know, it's just that life are difficult. It's difficult, right? So we have other things on our mind. We have our job in our mind. We need to complete something. We have our own mental health problems and so on. So what we would like to do is to really help parents engaged in the desired activity above the competing activity. And we want to do it in an effortless manner. How we do that? So first we have call to action. Just before the parents go back home from work, they get a text message that relates to the exact skill phase that they currently are facing. It has to be just in time, just before they're going to meet their child. So the desired activity is salient in their mind. It has to be positive, non-judgmental, and so on. We also, parental practices that we teach in each skill phase are then being documented using a daily report that the parents are automatically prompted to complete during evening time. It's logic-driven questionnaire, no more than 7 questions altogether. It takes less than 2 minutes to complete. But there is a reasoning to the way that we ask these questions, to the way that we monitor people. So we use a step-by-step script that tries to mimic the order of the desired activities that we would like the parents to perform. So for example, if we teach parents to overcome child non-compliance, we will first ask about whether they calmly approach their child, created eye contact, and ask them to change their behaviors. And then we will ask whether you did it, did you repeat this request only one more time, and so on. And the idea in this step-by-step script is that we would like to help the parents embed this new way of thinking. And because parents, they know they're going to be prompted to complete this questionnaire every evening, we hope that it supports their accountability for thinking this way during the day, okay? Because in standard programs, you don't have that. And we are also data-driven. So basically, based on this user state, we provide just-in-time feedback based on today a report. We also provide accumulated feedback based on different reports the parents accumulated so far, and also present, specific tips, information, motivational notes based on what parents reported about. And we also may decide whether the program decide whether to move them to a next step, to next skill phase based on what they reported so far. Okay, so why do I call it a focusing phase and not a training phase? Well, building a self-guided intervention requires a lot of humility, right? Because we teach a parent to do something today, any person, right? Even somebody with depression or whatever, it doesn't really mean that tomorrow they're going to act in the way that we would have liked them to act, right? We can't really foresee that. So we use a language where we ask the parents to focus on the specific phase within the next 1 to 3 weeks. And this is how we ask questions. Did you think about having positive interactions today? Did you have this in mind? And we tell them that when you have this in mind, you're doing a lot. You're doing a lot. And we try to do it this way in order to avoid the feeling of failure if we ask the parents to have, for example, 5 positive interactions in the day and they don't. The program is not good enough right now to give them this kind of granular, like specific personalized answer at this context. So this is why we build it as a focusing phase. This is just a small bit about the technological affordance. So it's a platform that I took, an open source platform, and upgraded it with a programmer. You don't need to understand too much about it, just that in order to build a logic-driven intervention, as a social scientist, I'm a social scientist. I mean, I am capable of a bit of coding, but not too much, but my PhD students, they can't. So we need to have a system that enables them to manage the information that is going to be sent to people based on different conditions. And this is what you see basically right now. So there are white nodes. White nodes are units of content. It could be a web page, a text message, a WhatsApp message, a Facebook message, and so on. And you have blue arrows that connects between different white nodes, different units of content. And in the middle of these blue arrows, you see the conditions by which the system decides which node to show, which unit of content to show after the other one. So those interested in the technical aspects of it, feel free to talk with me about it offline. So going back to the study, we took parents who have children with elevated levels of behavior problems, and we randomly allocated them to receive either the standard program or the therapeutic persuasive program. In terms of demographics, the average child age in this program was approximately 5 years old. There was a slight more number of boys in both groups, and there was no significant difference between the groups. Let's look into usage. This is the enhanced GROOM DPT, therapeutically persuasive DPT, and this is the standard one, okay? We can see that parents logged in approximately 4 times more to the enhanced program. We can see they also used it almost 2 times more in terms of time. However, this is not a fair comparison because parents in the enhanced program, they have this focusing phase, right? So they have many chances to log into the program that they don't have in the standard one. A better way to compare would be to look at module completion, okay? Which, so for example, overcoming disobedience, which is the most important module in our program where we teach parents to directly act in front of their child's non-compliance, you can see that almost 76% of the users in the enhanced program reached and completed this module, but only 37% completed it in the standard program. You can also see the same trend in terms of program completion. This is quite a large number in trials of digital interventions, and this would be, I would say, under trial, the standard number that you would get in many different interventions, not only in parent-trained programs. Okay, so this is the clinical outcomes table. Let me walk you through the important parts. So we are interested as a primary outcome in child behavior problems, like decreasing child behavior problems. We also want to see an increase in constructive parenting styles and parental sense of efficacy. What these asterisks tell you is that pre to post intervention, both programs worked, okay? There were changes towards the right direction in these measures. What you can also see is the difference between these programs that was significant only in terms of child behavior problems with a moderate effect size difference, okay? A moderate effect size difference in psychology between 2 interventions is quite big. We see here in the parenting metrics a small size effect. We don't know, what to make out of this. We just need to remember this is a pilot examination, less than 50 people in each group, so it might be a question of power. Okay, so of course this is a pilot examination, but the results are quite promising if we take the dodo bird effect into account, the idea that when you compare between different psychological interventions, all of them win. There is no difference between them eventually in trials. From my perspective, there are two key aspects to the idea of leveraging technological advantages to help people. The first is that quality is more than just having one feature or not. It's about how you embed this feature, right? I feel that I preach to the choir here, but eventually it's not about whether there is monitoring or there is not monitoring, but whether the quality of monitoring suffices. And another part is that in order to push the envelope, you need to target a whole therapeutic experience. So you want to target therapeutic process that helps people, and during this endeavor, you have to incorporate many different features to achieve this aim. I'm taking two future directions with this study. The first is a fully powered trial that we already started, where we compare between the two interventions in multiple time points. And we are very interested in this mediational pathway, where we want to see how parental usage of the program translates afterwards to changes in parenting measures, which then translates to child behavior problems. It's very difficult to do it, but we hope that we'll find this kind of pathway because we have many time points of examination. But what we are very interested in finding is whether this mediational pathway is different in the two programs, okay? Because bear in mind that the enhanced program is supposed to be very good at helping people change. So usage should translate to changes in behaviors in different ways. I don't know. Another future direction that I'm taking right now is and already started collecting data, is comparing between the guided intervention of the same therapeutically persuasive enhanced intervention with this unguided version. And the idea is, if we think about what human support provides to people, it supports their accountability in using the programs. They monitor their activities, they provide them with just-in-time feedback about what they're doing right and not, and they try to make sure they are there to the program. And nobody yet tested whether using an automated features could change the need in this kind of human support. So I think that we'll have the complete data by this May. Very looking forward to it. So this was my first proposal, which was more technical. It was about the digital interventions, utilizing technological strength. And I want to suggest two more things. So the first is that the service should accommodate real-world users' needs. What does it mean? This is my offered conceptualization of population needs. Right now, we look into it through the lenses of healthcare systems, okay? So all these blue dots are people that go and seek psychotherapy, okay? They are varied in terms of their levels of symptom severity. Some have mild, some have moderate, some have very severe symptoms. However, all of them, by going to psychotherapy, already exhibited some readiness to be treated and showed that they find some sense of importance in psychotherapy. Why? Because they have to go out from their home and speak with a general practitioner and say, I have a problem. They had to pay if it's a private clinic. They have to travel to the clinic and get it. So our models in psychotherapy are built to help these kind of people that already invest some effort into receiving care. But if we think about population needs through the lenses of public health, we get to see all these red dots of people who don't reach traditional services. And a large chunk of them has moderate levels of symptom severity. However, they just don't have the same sense of importance or readiness to be treated. So they don't go ahead and seek support due to various reasons that I'm going to touch. But eventually, these people, they are going to open an app. They are going online and try to do something. If we want to help them using digital mental health interventions, we need to take into account that the readiness to be treated or the amount of effort that they want to exert in the intervention is much lower than in psychotherapy. So we can think about it from an effort optimization perspective, right? And there are some things in digital interventions that could be very, very easy to make effortless. Like, for example, most of us have in our smartphones, having the color changed in the night. So when we open the smartphone, we go back to sleep much easier. We don't exert any effort into this, right? But doing an e-learning course, even if you are not under mental illness, is very, very tough, is very, very difficult. So one way to think about it, we already discussed the design of the intervention, right? So for example, if we silently set up the right desired activities above competition, it might be that the experience of people is that it was less effortful to engage in these activities. But another way to think about it is ask ourselves, what are the immediate concerns of people? What people are really concerned of? And trying to build them interventions with much more targeted objectives. And in this way, the interventions themselves are much more simpler, shorter, and they demand less effort to engage with. Micro-interventions are a set of interventions that meet this kind of aim. And there is one popular subgroup of micro-interventions that people in the psychology field research a lot these days. These are single session interventions. I don't know if you heard about it, where you get in one session, they teach you something, and that's it. You go home, okay? But there are many other subgroups of micro-interventions. So for example, if you prompt somebody to stand, because in order to avoid the back pain, and you do it in multiple points of times, this is also a micro-intervention. But the objective is very, very functional, immediate concern. It doesn't relate to a large clinical target. And we all engage micro-interventions all the time, right? I'm right now drinking my bucket of water. Okay, we go out for a walk. We speak with someone when we feel bad. We do it all the time. If we do it well, we might have better resilience, right? And because we have smartphones in our pockets and technology is all around us, we can think about pushing to people the right digital micro-interventions at the right time. So we have this kind of a digital micro-intervention care. Now, there are many complexities that relate to it, like, for example, how the hub performs. Hub by, understanding user state and pushing the right micro-intervention to the right person at the right time and so on. Those who are interested in this kind of route, I write about it. I delve into it with two fabulous researchers in this paper. But going back to functional aims, if we take the realms, for example, of parenting, well, treating child behavior problems, treating child anxiety is big aim, right? It also requires a large interventions and many effort exerted into it. However, if we think about, for example, a micro-intervention that teaches the parents how to moderate their child's play because they just now went on play date and found out that the child, misbehaves, right? And if you teach them based on this immediate concern, you might help, from things to get deteriorated afterwards, and develop much larger social problems. And we have to take into account that in earlier stages of experiencing difficulties, this is what people care about. They don't care about anxiety. They don't care about depression. They care about specific problems, that immediate concerns that they currently have. And if we build these kind of interventions, we might see that we have much better uptake of them. This is one future direction that I'm taking in order to add some more clarity to this in this perspective. So basically, this is a 30-minute program. Users, they go online in order to learn, to get a full report about their emotional well-being. I don't have a good name in English. I have a very good name in Hebrew, and it's out in Hebrew this month. And in MindTools.io, it's going to be out in 2 months' time. If you have a catchy name, please help me. So basically, the users, they feel a logic-driven assessment battery where we try to target all their mental, based on self-reports, their mental illnesses, but also many other things that relates to emotional well-being. So, for example, we want to ask, we're asking about their financials, about their relationships, about their employments, what they care about right now, how much effort they want to exert in any sort of intervention. We don't meet them at the traditional healthcare setting, so we do hope that we'll be able to understand how real-world users, experience their needs. And what they're going to get in return is a full feedback, automated feedback on their reports. It's nice graphically, but it's like 10 pages. You have a short one, 2 pages, and then everything complete like in another 8 pages. And we're very interested in understanding intervention preferences, like what kind of things people look for, right? How much does it interact with symptom severity and these kind of things, hopefully to be able to to address real-world users' needs in better ways. The last proposal is that the intervention should utilize the relevant active ingredients for change. Okay, so raise your hands, whoever, everyone that likes strawberry with a chocolate topping. Okay. Cool. Duncan, you don't like strawberry? Okay, interesting. We'll talk about it offline. So now keep raising your hand, raise your hand again if you like broccoli with a chocolate topping. Okay, yes. So if I reductionize my work in a very non-responsible way, okay, basically what we talked about so far is getting the right information from users at the right time and pushing them the right information with the right medium, with the right presentation at the right time, right? But this does not mean that it is the only way we should help our users, or we could help our users in the same manner that, chocolate topping doesn't fit any dish. In fact, we can manipulate different active ingredients in order to foster change based on users' needs. We can also increase the availability of therapeutic connections. So this is one very interesting study that I conducted in this realm. It's in Zucker Hillside Hospital in New York, where I met with the perinatal unit over there. And we thought about how we can complement the treatment for women with perinatal depression. It was like something like, I think, 8 years ago. And eventually, I came up with using 7CAP's platform as an adjunct to treatment. So 7CAP is an emotional support system. It's online. It trains volunteers from all over the world to provide emotional support for active listening, no consultancy, based on a computerized training, and then engages them with people who seek this kind of emotional support. This is chat-based, okay? Back at that time, 7CAPS had something like 250,000 active volunteers in all over the world in 60 different languages, okay? And how 7CAPS empowers so many volunteers to be there. So basically, it's very easy to finish the computerized training, really, very easy. And you can just press things, and move over. But you also get to be there for someone else, which I guess raises people's curiosity, and people want to be good, and it reduces the effort in doing so. But then there is a natural rewarding system that is very, very complex and interesting with different badges that users eventually see and like. And the listener's reputation is built along the way. So the native users, they meet these, they chat with these volunteers, but then they rate each of the emotional support chat that they received, each of them, okay? So you get this kind of a very clear reputation, how many reviews, how many support chats this volunteer was engaged with, and what people thought about them. So in this program, what I did is, with the perinatal unit, okay? What I did is to write another computerized training that teaches these volunteers how to support women with perinatal depression. And I only chose volunteers that also had very good star reviews based on native users of 7CAPS. And then we engaged them with these women. So basically, participating women with perinatal depression could get access to this 24/7 chat-based support from trained volunteers, okay? And there are many interesting findings, including clinical outcomes in this study, but I want to focus on one that really relates to the idea of, manipulating the relevant active ingredient for change. So this is the daily time windows where these women used and talked with volunteers. And eventually what you see is that 50% of app use was during nighttime, mostly during nighttime. So we asked these women, how come? And what they explained is that they used 7CAPS also in the day when they felt lonely and they wanted to chat with someone. And during the night, they had, nobody around them that could help them. They felt exhausted, they felt miserable, they were very, tired, but they needed somebody to chat with. So they had these volunteers. And if we think about the experience of perinatal depression, it makes sense, because we know the sense of loneliness and lacking social support are very salient experiences in the feelings of women with perinatal depression. We also know that lack of social support predicts the occurrence of postpartum depression. So it's not surprising that they found the support of these volunteers very helpful, and they wanted to use them when they didn't have it in other places. Now, the reason that I'm saying it like that is because, well, if somebody experiences loneliness, it might not be the best thing, the first line treatment, to offer them an unguided application that pushes information towards them, even if it's evidence-based cognitive behavioral therapy or something. It might be better to connect them with someone else. And it reminds us that we need to activate the relevant and not the most convenient active ingredients for making change. And yeah, with technology, we can do that. We just need to be creative enough. So these are my three proposals. By the way, I said 4 because, well, I see you guys, and I learned on Friday that I'm going to be lecturing you after many of you are going to be in many presentations. So I reduced it from 4 proposals to 3, and I really, really shortened it to finish it in 35 minutes and not in 45 minutes, because, this is part of accommodating the real world users' needs, but also the context, right? So you can think about these proposals also in terms of condition for successful deployment and development of digital mental health interventions. I hope this, inspires some thinking, and we'll be happy to talk about it some more and have a dialogue about it. Thank you.
Thank you very much for that talk. Any questions, Enrico?
Thank you. Very interesting. Quite a lot of questions, but I'll try to focus. I'll start from a comment on one of your slides. Can you go back to the one where you had a scatter plot with the blue dots and the red dots?
Yes, I do it like that because I'm afraid from the projector.
Yeah,
yes.
that's it. Perfect.
Okay.
It's a minor article, and then the real question comes. You have some red dots, which are overlapping with the
blue dots.
Blue dots.
Yeah. Why?
Who are these people who basically have high readiness to be treated, but not necessarily go for it?
This is a great question. Thank you. When I present, I don't have the time to present everything. No, I need to focus. But this is a great question. And basically, these people are actually very much researched. These are people that don't go to get treated because of stigma, because of cultural gaps, and so on. They want to be treated, but they are afraid because of this. And there are many studies on them. You don't have many studies on these people, however.
That's really interesting. And then what for me is the real question is, all of the, and this is follow-ups from a chat we had before the presentation. All of this is people who anyway are gonna be self-selected and seeking help. You're lowering the threshold, but they still fall in that category. Did you look at all at instead group of people who essentially get prescribed? And it may or may not apply to mental health. I'm not familiar enough. But I asked because I'm doing some work in the context of COVID or long COVID, and we started to be intrigued by the fact that, as you mentioned, a lot of work in this space comes from HCI around personal informatics. However, personal informatics is often something that is spontaneously done, right? So it's you have an interest in tracking, and that I think defines a very specific subset of the population. But what if all of a sudden the doctor tells you go and do this? Did you do or see any work in the space?
Yeah, so basically this relates to the proposal. I would just say that all these proposals, I see them as different lenses. You can put all of them together. You need everything to be successful, in my view. So the first one regards how do you distribute it well? And I'm not sure if I think we discussed it before, but in our conversation, but when a general practitioner prescribes someone with digital interventions, they are not really acceptable. In the UK, the last data that I remember reading about was less than 20%. Okay, so the people say I have a problem, and then you say get a digital application. People don't like it. And by the way, there are many right now endeavors, country-wise, that go for this model. You have DIGA in Germany, Pecan in France, that help startups in digital mental health get be in the list of prescription therapeutics. Okay, and I think that the reason that you see that people don't like it is because once they already got to the general practitioner and said they had a problem, it was like after 7 years of having anxiety, 5 years of having depression, they're like, man, they need right now a human being, a caring human being that is also a professional, in my view. Okay, but you could think about it from a national implementation perspective. You don't need to only think about self-selection. When you're going to meet the population, it's the right place in order to offer them the services, at the right time. And my example of the other proposal was in Finland, there is a digital parent training program that, and I work with the center on automating it. Right now, it's human supported, but basically what happens over there is that parents take their children at 4 years old to a medical checkup, and all the parents do it. Okay, so then in implementation, in third of Finland, these parents are being asked to complete this screening of their child behavior problems. And those who are screened positive offer the intervention. And eventually what we see, we don't see 20% of people want to do it, or less than 20%. We see more than 60%. Okay, so and it's not a selection because it's a national based, and you could have it here. In the school system, you could screen all children at the age of 9 or 10, all children, like prompt it. It doesn't have to be with a lot of burden, with the right questionnaires, screening questionnaires to the child and the parent. Boom, everyone that deserves gets a digital intervention. And then those who are, and like after 3 weeks, that you don't help. So you can provide a linkage to care. Much better way to think about, implementation.
Thank you.
Thanks.
Anyone else?
I also have a few questions, but I'll ask one. Yes. Okay. So here you see like again a range of people in various kind of like points of like, let's say, intervention. And you mentioned let's say if you were to offer a digital intervention, that means that some of these users are coming to a tool with various levels of like a starting point. So my question is the tool, or are you thinking about having different starting points to the tool based on where the user is at emotionally?
So I didn't think about it, honestly. It's a great idea. I think this also relates to the relevant clinical target. So if you try to target early onset of child behavior problems and you try to reach, children at the age of 5, approximately you reach them at like with a smaller variance of problems. But if you're going to try to help these children between the age of 4 to 12, you're going to meet conduct problems. You're going to meet like some very scary things that, they are much different. But I think, there is a lot of room to think about personalization based on that. So you take the same program. Right now, it's for parents of children between the age of 4 to 8. And you also try to measure where they are at in terms of illness deterioration, how much time it evolved, and then you may build different interventions based on that. Yeah, could be possible.
Does anyone else have a question?
Yeah, again, thank you so much for the presentation. I was really interested what you said about loneliness and finding that correlation with use of 7 Cups, particularly because I learned actually during last summer, marking some of the master's thesis, that young people use dating apps because of, not just to find dates, but just to find friends because they're lonely, particularly when they've gone to different countries. But coming back to 7 Cups, I just wondered how it has changed over time, because it's been around for some time now. So I just wondered if you could give us an update on where it's got to,
Yeah.
and also whether you think, or where you think digital phenotyping is in terms of identifying people with psychological issues.
Okay. Okay, so let's start from the first question. If I forget the second, you remind me. So 7CAPS, right now I do not collaborate with them, but I am right now with like personal connection with the founders. So I know like approximately where they are at. I think that what happened after several years, that they first become very successful at building an ecological system, if you will, that really works. Like there is a balance within the community over there that is very interesting. So volunteers, they get there to get one thing. People who want emotional support, they get it for another thing. People who write within their community tabs, they do it for another thing, and so on. This is one thing that happened. The other thing that happened, you know, and this is if I understand correctly, because this is, I mean, you can go online and see it yourself, is that in order to finance themselves, and I think just to bring it to balance, not trying to be like a huge company that, you know, worth billions of dollars, they do have right now advertisements for therapists within the platform. Like there is Talkspace, chat-based, based on therapists. They do have it themselves, and users, they are prompted, they have this option to on the screen to press on the therapist, and then they will pay for this service. So this is where they are at right now. I think that currently they don't have the same traffic that I shared before. They don't have 250,000 users. In my view, this is more of the you know, motivations of the entrepreneurs and how things, you know, the dynamics and what you want to get from your company more than anything else. To your second question, can you remind me?
On digital phenotyping.
By digital phenotyping, do you refer do you refer to the idea of trying to understand mental illnesses or mental health characteristics by
prevention of episodes of mental illness through technology use,
through passive sensing and so on? Okay.
Active sensing.
Excuse me?
And active sensing.
Like
Changes
self-reports.
in speech and typing.
Yeah.
And,
Yeah. So I don't know. I can't share you specific empirical data, but this shows that it failed so far. Okay, but I'm going to like I want to back what I said right now, because I'm saying many people in psychology still try to do this.
Yeah.
So I really want like to justify this claim. So basically, we have Google, who invested something like $30 million in this, didn't succeed. We have MindStrong, that was built with Tom Insel, the NIMH, the lead director, when he left Google to this endeavor. I think they got $10 million. I think for that, and only for that. And they are quick. This is a startup mode. This is not academy, and they didn't. I mean, they were closed, and we don't know what happened. So I take a guess that they weren't successful in that. Okay. So I think, okay, we know what is the challenge, right? We are definitely good in identifying based on speech, based on other things, depression, anxiety, this kind of thing. We are good at that, yes. But the problem is noise. The problem, what we do is noise. And the problem is selection. Like, who are the users that you eventually reach? So some of these problems are mechanical in my view, mechanical in the sense if you get the right distribution channel, you might have solved it. But I guess that some of the problems relate to the techniques, the technology may be not good enough yet. But this is a guess. This is a guess just, you know, as somebody who looks from outside and say, well, you know, if it looks like a duck, it walks like a duck, you know. So many money was put into this platform that didn't succeed. So this is my guess about it.
Thank you for your talk. It was very interesting. I wanted to ask about the mindfools.io website. Seems like a wonderful resource. I was wondering how you came up with a way to evaluate these. I noticed there was an expert review on each of these applications, and I haven't come across anything quite like this before. So I was wondering if you could talk a little bit more about how these how you produce these ratings,
Yes.
and whether there's been any interest from developer side of the world in this type of way of evaluating a whole cavalcade, what it looks like, of apps. Thanks.
Yeah, great question. So first of all, thank you. Yes. Good. Okay, so first of all, the first app website that provides recommendations, to my view, I mean, to my knowledge, actually, was beacon.au in Australia. It was founded by, I think, Helen Christensen, which did, amazing things. She's like very good entrepreneur, researcher, if you will. I think it was like 70 years ago. MindTools, the idea at the beginning was eHealth clearinghouse. So 7-8 years ago, many people thought about the idea of, let's try, we can't really test all these interventions, and people are using them. So let's try to do this eHealth clearinghouse, understanding the ratings. This is how we came up with it. And at that point, CyberGuard was already, up and running. I think, I'm not sure about Orca, but there was something in the NHS. Right now, it's still working. And what I found out that basically these applications are not based on evidence-based, way of how we examine the user experience. So they do examine different things, but not the user experience of the product. And this is why I decided to build like the scales that we're using in order to rate these programs, and you have it in resources over there. So this is just a bit like of history. I think that from that perspective, the idea was, if you get good enough ratings, like very in-depth reviews for each product, so people would really like, looking into this website and to decide which kind of products to use. I think that and two things about it. So first of all, I still stand behind the ratings. Okay, so basically, if you go to NHS rating of a certain application and look into my rating and you see difference, I bet you a falafel that my works and then they don't. In terms of user experience, really, I looked into that, and check me. I mean, I'll be happy to learn. I mean, and to adapt something, right? But I'm not going to mention programs, but so this is from the scientific perspective. However, something happened within these 7 years. Once you build this kind of thing, you really want to change the world, right? And then you learn that eventually most users, they don't do this, right? Like in Men in Black, the first movie, there is one of the quotes, "The person is smart, the public is stupid." So what it means in this extent is that, people, they just go online, they go into the app stores and they just download something like that. Another thing, I think that the app stores became very good, at least Apple, in the app reviews that they show. Okay, so it's not the same thing, like rating of user experience, but it is something. Okay, so this has changed. So it's like, if you have 50,000 users per month, it's still, nothing, like a tip drop than what people download. So the reason I'm renovating it right now is because I think there is room for a global digital clinic, actually. And I think that this should be like one of the ways to start, but you need to have a very good mental health assessment, like screening to provide people, like, and then you could think maybe about also providing interventions, not necessarily those that are currently being reviewed. But this is why, like, right now I'm investing in it.
Yeah, I think so.
Oh. Yeah. So another round of applause for Amit for his presentation.
Thank you.
The conversation can continue after this, though. So we'll close off this session now, but we're going to be heading to Torrington Place.